It's now my real pleasure to introduce someone who is speaking for us for the first time this year, Dr. Matt Evans. Oh, you're there. I didn't see you. I didn't see you sneak quietly up there. Matt is going to, he is from the Central and South Genomic Laboratory Hub and also University Hospital Southampton. But he's going to talk to us about molecular profiling, what it actually is and what the findings might mean. So over to you. Thank you.
Well, thank you for that introduction, and thank you as well for the invitation. And most of all, thank you to all of you for being here, being conscious that a lot of you have come quite long distances to be here. What I'm going to do is briefly go over how we do molecular profiling, so what we're looking for, how we do it, and potentially what the results might mean. Those are my disclosures. So, as I say, 3 key questions which I want to cover here. First of all, what are we actually looking for? So what do these molecular alterations look like? Then, which technologies can we use to pick them up? Why might you use one or the other? What are their strengths and weaknesses? And then finally, being very conscious that I'm not an oncologist, what might happen with those results once we have them? So first of all, what are the things that we're looking for? Now, the first thing to say is that there are lots of different molecular alterations, but the majority of them will fall into one of these 3 groups. So at the one end, we've got the small sequence variants. Those are basically small spelling mistakes in the genome. So it's things like this. So you can see that you've got letters swapped around, you've got a few letters inserted, a few letters deleted. So small spelling mistakes. And that's what they'd look like in real life. Structural variants, though, are really very different. These aren't small spelling mistakes. This is where you're taking entire lines of a paragraph and moving it to an abnormal location in your block of text. So in real life, it would look something like that. So you take a gene from the chromosome that it normally sits on and move it to a chromosome that it doesn't belong on. So big chunks of genomic information. And then the final type of alteration is the copy number variants. And that's kind of what it sounds like. It's where you've got an abnormal number of copies of a particular region of the genome. So it would look something like that. So from our quotation, I've duplicated that final line a few times. And in real life, it would look something like that. So you should normally have 1 copy of each bit of each chromosome, but there you've got 4. So that's an amplification. Just to say, I have fibbed a little bit. It's not quite that simple, and things never are. There are actually lots of other different types of molecular alteration, but most of them will fall into those categories. So having laid out what they are, how do we actually look for them? And what I'm going to do here is specifically talk about the tests which we use to profile cholangiocarcinomas. I'm going to start with the mismatch repair system. So whenever a cell divides, you need to replicate DNA. And whenever you replicate DNA, just like when you're writing something out, you will make spelling mistakes. So you can see there, we should have a G, but instead we've got an A. So that is a mismatch error. Now, fortunately, we have a very clever system called the mismatch repair system, which is constantly on the lookout for these mismatches. It's made up of lots of different proteins, but the key ones are the ones which I've listed there, MLH1, PMS2, MSH2, and MSH6. If they detect one of these mismatches, they will come along, remove that mismatched base, and replace it with the correct base. So the important point here is that if your MMR system isn't working normally, you'll be sustaining these errors, but they won't get repaired, meaning that you'll get more and more and more over time, and you'll end up with a very heavily mutated genome. The reason that that is important clinically is that patients with these very, very heavily mutated genomes are more likely to respond to immunotherapy, as we've already heard. So it's important for us as pathologists to be able to test to see whether this system is working normally or not. And we've got 2 tools to do that. The first is with MMR immunohistochemistry, which is what we tend to do in the pathology lab. And then we've got microsatellite instability, or MSI testing, which is what tends to happen in a genomics lab. So what do those technologies actually look like? Well, let's start with mismatch repair immunohistochemistry. Now, Tim already talked you through how we process tissue in the lab and how we do immunohistochemistry. If I want to do MMR IHC, what I'll do is get 4 sections cut from my tissue, and I will stain up each of them with an antibody which will pick up each of those proteins which I listed on the previous slide. And what you would expect to see is that all of the 4 slides would look very brown, like those 2 ones which I'm showing you at the top there. If all 4 of those slides look very, very brown and not very blue, The MMR system is working normally. We call the tissue MMR proficient. However, if any of the slides look like the two which I've shown you on the bottom, like MLH1, PMS2, that means the MMR system is not working normally. That means that the tissue is MMR deficient, and those are the ones that may respond to immunotherapy. Very conscious by saying that I'm making pathology sound quite straightforward. I promise it's not just brown and blue. Microsatellite instability testing is something really quite different. So here, we extract DNA from the tissue, and then we use that DNA to look at the lengths of structures in the genome called microsatellites. If you have a normally functioning MMR system, all the microsatellites will be roughly the same length. And if you plot them on a graph, you'll get these nice curves. That's telling you that the MMR system is working normally. The tissue is MMR proficient. But if the MMR system doesn't work normally, those microsatellites will start to vary in length, and you'll find that those graphs end up having these little double peaks. That's telling you that there's microsatellite instability. That means that the tissue is MMR deficient, and again, the patient may respond to immunotherapy. So really just two approaches to looking at the same thing. But obviously that's not the only thing we test for. There are lots of targets nowadays in cholangiocarcinoma, and of course we need to test for all of them. You've got the IDH1 small sequence variants, so small spelling mistakes. Then you've got the rearrangements, so the large-scale alterations in FGFR2, NTRK1, 2, and 3. And broadly speaking, when it comes to profiling, there are two paradigms. What we've tended to use historically is what we call single gene testing. So you use one test to look at each gene which you're interested in. So if you wanted to profile a cholangiocarcinoma, you could do all of these various tests looking at each of those genes which I've listed. Now, the obvious problem with that is that with a cancer like cholangiocarcinoma, where the number of targets is growing rapidly, that approach is going to become very, very cumbersome very, very quickly. And so it's partly for that reason that over the last few years, there's been a massive shift towards next-generation sequencing or NGS panel testing. A single NGS panel will cover multiple genes in parallel. It will sequence all of them, and then you can choose from the data which genes you're interested in looking in. So if you wanted to profile a cholangiocarcinoma, you could do a DNA panel looking at IDH1 plus other genes if you're interested in them, and an RNA panel looking at FGFR2 and NTRK1, 2, and 3, again, plus any other genes which you might be interested in. What I'm going to do now is just go through a little more detail about each of these two approaches. So let's start with the single gene technologies. I kind of cast these aside a minute ago by saying this is what we used to do, but they do still remain important. An example of a single gene technology is real-time PCR. So we've got some DNA there, and it's got a mutation in it. We will then use a real-time PCR assay, and within that assay, you have multiple probes, each of which will bind to a particular mutation which you're interested in. So in this case, that probe will bind to the mutation which is present. We'll see the green fluorescence which is attached to that probe, and that's alerting us that the mutation that represents that probe is present in this sample. This is a really good technique in many ways. It can be super, super fast. It works in things which won't work with anything else, so it's got a very high success rate. But the problem is that if there's a rare mutation in your tissue that you're not expecting, you probably won't have a probe which will pick it up in your assay. So this technology will miss rare mutations which may still be clinically relevant. Now, FISH, fluorescence in situ hybridization, is a technology which we've used for very, very many years, and it's served us very well. The idea here is that you look at your tissue down a microscope and you apply fluorescently labeled probes to it. And I'm not going to go into the detail here, but if you see the two colors next to each other, as in this case, that's telling you there's no rearrangement. But if there is a rearrangement, those colors will split apart. So it's quite a neat idea. You look at it down the microscope, you see the colors are split apart, that's telling you there's a rearrangement. And again, this can be super, super fast. It works even in very low quality tissue. But again, the problem is that it can miss things. If the genes move only a short distance, you may not be able to perceive that down the microscope, and you may end up saying that something is negative when actually there is a rearrangement present. And it's partly because these technologies do occasionally miss things that there's been that move towards next-generation sequencing. In next-generation sequencing, what you do basically is scour particular regions of interest in genes which you're looking for, and you should, in theory, identify any mutation which is present within those regions. So it's far more exhaustive. But it's worth saying that NGS isn't a single thing. It comes in lots of different flavors. At the one end of the spectrum, you've got small NGS panels, which will cover a few dozen genes. And we use this one quite commonly in our genomic lab in Birmingham. On the other hand, you can have very large NGS panels which cover 500 or more genes. And you might think, well, why would you go for this rubbish little panel? You know, that's going to miss things. It's not going to give you as much information. It's a valid point. Ideally, everyone would have a large panel. But it's not all quite as good as it seems. The large panels often take longer. They often have higher failure rates. So I think there's a balance to be struck here. So if you ask the question, which is the best method for profiling a cholangiocarcinoma, my cynical answer would be it's kind of a silly question in a way, because these technologies differ in so many respects and have such different strengths and weaknesses that I don't think you can really definitely say one is the best, another is the worst. It really depends on the scenario. This sounds a bit cliche, but I think personalized care requires a personalized and tailored approach to testing and profiling. If you've got a patient who is really poorly and you need to get them on treatment right away, you probably can't wait for a large NGS panel. And probably the most sensible thing to do is to use single gene technologies, accepting that there may be a very, very small risk of missing something. Conversely, if you've got a patient who has exhausted all standard treatment options and you just need to find something that you can do for them, well, it has to be a large NGS panel, and you have to accept that that will take longer. But I think there is a role for optimizing logistics behind all of this to make that more deliverable. So, finally, what do we do with the results which we obtain through this testing? Well, that's an example of a report which comes from our genomic laboratory in Birmingham. It's probably a bit too small to read there, but that report is saying that an FGFR2 rearrangement has been detected in the tumor of a patient with cholangiocarcinoma. And you can see on the far side of that table is showing you a list of all the genes which were covered by those NGS panels, so you know exactly what they've looked at and what they haven't looked at. And I'm not going to go into this in any great detail because I'm sure you're going to hear about that in a moment from John Bridgewater. But what I've listed here are the targets which are currently actionable in cholangiocarcinoma in routine practice. I've already mentioned MMR immunohistochemistry and MSI testing and how they can be used to inform immunotherapy prescription. And then in addition, there is treatment available for IDH1 small variants of particular types, FGFR2 rearrangements, and NTRK rearrangements. But I don't think it's just in terms of getting patients onto the optimal treatment that molecular testing matters. I think we as pathologists probably need to have a better awareness of the fact that molecular testing can also help us to make more accurate diagnoses. Now, I've misled you, I'm afraid, because I told you this was a report from a patient with cholangiocarcinoma. And in fact, it is. But we actually thought this patient originally had lung cancer, widely metastatic lung cancer. Difficult to know where it was coming from, but we thought overall probably coming from the lung. So I sent that off to our genomic laboratory to have NGS to look at the lung targets. But because we used NGS, which looks at all of these other genes as well, it incidentally picked up an FGFR2 rearrangement. Now, you can certainly see that in lung cancer, but it's extremely rare. So I bounced this case back to the MDT for rediscussion, and in the end, we felt that actually, on balance with this result and looking at everything again, this patient is best managed as a cholangiocarcinoma patient. And I'm pleased to say the patient is on targeted treatment at the moment and is doing very well on it. So an example of how we can use this genomic information not just to match patients to treatment, but to make more refined diagnoses. And speaking of diagnoses, I wanted to close just by saying a few words about what is a diagnosis, which kind of sounds like a bit of a silly question. We all kind of know what a diagnosis is. But the concept of a diagnosis changes over time. A long time ago, it was acceptable just to say this patient has cancer, no further information. But our radiology improved and we were able to say where that cancer was in the body, and that improved the quality of our diagnosis, improved the quality of our treatment. Then we got better at pathology. This isn't quite chronological, but you'll have to bear with me. We got good at looking at tissue down the microscope, and we were able to make even more refined diagnoses. Say this is adenocarcinoma of the liver. Then we got good at telling what proteins the tumor cells are expressing, and we were able to subdivide it even further and say this is a cholangiocarcinoma. And at each of these steps, what came before was then regarded as unacceptable. You know, it would be unacceptable nowadays to give a diagnosis of just adenocarcinoma of the liver. We should be saying it's cholangiocarcinoma, it's hepatocellular carcinoma. And I think right now we're on the brink of moving to this. And I controversially, would say that actually nowadays a diagnosis of just cholangiocarcinoma full stop is probably not enough. And I think our diagnoses should look more like what I'm showing you there, where the diagnosis includes the molecular profile, because what we've seen in other solid cancers is that these things very rapidly become absolutely central to everything in terms of patient management. So with that slightly controversial note, thank you very much.